Hi, everyone. My name is John Faulkner, and I am your host of the Smarter Systems, Better Care podcast. And today with me is Dr. Ali Rifai. He is a nationally recognized leader in the telepsychiatry and integrated mental health care space. He is the founder and CEO of Blue Mountain Psychiatry, and he's also a board-certified psychiatrist, internist, and addiction medicine specialist joining us today to share his insights on the evolving landscape of mental health and addiction treatment. Thank you for joining us today, Dr. Rifai.
Thank you very much for having me. I'm delighted to talk to you about my experience in psychiatry and telepsychiatry and where the mental health system is going these days.
Absolutely. And would you mind just sharing with our audience, kind of tell us a bit about your background, your business, and the clients that you serve?
Absolutely. So by training, I'm an internist and a psychiatrist. I did my training at the University of Virginia in internal medicine and psychiatry, and I'm board certified in internal medicine and psychiatry. I also did additional training in consultation psychiatry as well as addiction medicine. I'm board certified in addiction medicine and consultation psychiatry. And following my training experience at the University of Virginia, I actually moved to the National Institute of Mental Health in Bethesda, Maryland, where I was there for 3 years, did some cutting edge research on the utilization of additional medications to treat depression. We did research on ketamine. We did research on transcranial magnetic stimulation. And we also did research on telehealth. And following my experience at the National Institute of Mental Health, I moved to Pennsylvania, and I've been in Pennsylvania almost now for 20 years. My first job in Pennsylvania was working for a local multi-hospital health system in the Lehigh Valley area. And that was a very interesting experience because it was catering to rural population. And that's where my roots and beginnings working with telehealth and telepsychiatry. Those days, nobody had heard about telehealth or telepsychiatry, but we basically were intent on providing psychiatric services to rural population in Pennsylvania. And we actually established one of the first emergency telehealth programs in the country in 2006. And funny, kind of just we're having this nice interview with very minimal equipment, but I can tell you the hardware for Tandberg, that was the name of the company. I don't know if they're still around. They did telehealth equipment, and basically the equipment was a big box that weighed about 500 pounds.
Oh, wow.
And it had big screens. So that was the server for the telehealth. And 3 telehealth stations cost at that time $3 million. That was a lot of money in
That is a lot of
2006
money. Yeah.
But that's where the expense is now. Now you have a $50 iPhone or a smartphone, and you're in business in telehealth. So that was pretty interesting. So basically, we started this program and transitioned into actually offering some of this expertise to other fields of medicine. I helped them also establish their tele-ICU program, and this was in 2010. Yeah. And this tele-ICU program was instrumental when COVID hit in 2020, 10 years later. That tele-ICU program was ready from day one. They hit the ground running. They were able to manage multiple, many critically care ill patients from a central location while being able to provide appropriate care. This was when COVID hit. So I've always been on the cutting edge of kind of providing services to my patients. I'm proud of that kind of history of writing and talking about telehealth early on. I have writings and articles that I wrote about telehealth in 2010, 2011, 2012, kind of talking to other colleagues and other psychiatrists about telehealth and telepsychiatry.
Excellent. Well, thank you for the background. It sounds like you're truly like a pioneer in the space, and the cost of that is astronomical at first. I mean, that must have been quite a lift to get that going at first. So literally.
And there was interest in, I mean, that health system was on the cutting edge. They were interested in newer modalities, new things. And the CEO at that time realized and had the vision to basically be able to kind of realize that. So we were lucky that he realized the importance of telehealth.
Yeah, the right time, the right place. And like, as far as like getting back to your business too, like, what's the core focus of like your business today, and what role are you playing in driving that growth kind of moving forward?
Sure.
Yeah.
So after working for a health system for about 5 or 6 years, I realized that there were a lot of things that a health system may not be able to achieve,
Yeah.
and that is restricted. So I wanted to do a lot of cutting edge research. I wanted to do basically, I wanted to focus on doing, for example, transcranial magnetic stimulation, which was a FDA approved treatment for treatment refractory depression. I wanted to do ketamine treatment. I wanted to do more telehealth. And working in a health system kind of restricted some of that.
Yeah.
And so actually, I decided to start my own practice. And in 2011, I started my own practice, Blue Mountain Psychiatry, and still going on strong. Almost now 15 years later, the practice is going on and expanding. We're re-expanding and moving forward. We're in 3 offices. We provide cutting-edge treatments. We provide transcranial magnetic stimulation. We provide ketamine treatment. We have some new treatment modalities. We provide medication management. And the business kind of expanded and then deflated a little bit, and now we're on the up and up again and expanding again. So I'm happy that the business is moving forward and doing very, very well.
Excellent. Yeah, that's great to hear. And then if you were to kind of like make a pitch to someone, like what would be your competitive edge in like 30 seconds? Like what makes you different than other similar practices?
So Blue Mountain Psychiatry provides personalized care for individuals with severe psychiatric illness, specifically treatment-resistant depression. We provide interventional treatments, including transcranial magnetic stimulation, ketamine treatment, and we provide genomic testing as well as AI-driven biofeedback to treat depression and anxiety. So we feel that some of these interventional treatment modalities gives us a edge over other practices that are basically in the model of medication management, seeing patients for 15 minutes and providing them prescriptions and moving on, while we actually dig into the core of a patient's symptoms, doing interventional psychiatry and trying to use other modalities other than medications.
Yeah, you're kind of diving in more of the preventative medicine area, right? It sounds like more of the source of what's actually causing them to keep coming back and asking for more management of what's going on, right?
Absolutely. Absolutely.
Yeah. And then like what's one shift in your industry that you think most like founders, CEOs are underestimating? Curious to get your take on that.
I think the developing and evolving technology. So there's a lot of technologies that are evolving, interventional treatment modalities that are evolving in psychiatry, and I'm talking specifically about the field of psychiatry. Artificial intelligence. So, for example, one of the treatments that I talked about, which is called Prism, which we're offering through our office, basically is an AI-powered biofeedback model that treats depression, anxiety, and post-traumatic stress disorder. And it's actually FDA approved for depression and post-traumatic stress disorder. And what involves is receiving biofeedback from EEG monitoring of the brain and retraining the brain to calm down and be able to control the signals of depression and anxiety through an AI interaction with avatars on the screen and being able to control depression and anxiety. We're also involved with AI medical assessments, psychiatric assessments, for example, assessment for tardive dyskinesia, assessment for basically other worsening of psychiatric issues with measurements, depression, and anxiety. And we are also doing a lot of genomic testing that's AI augmented, which helps us figure out which medications patients may experience adverse effects to and try to avoid those medications when prescribing that and adjust the medications based on genomics and based on correct psychiatric assessment of patients. Also, we talked about the interventional approaches with transcranial magnetic stimulation. But if somebody is in the field of psychiatry, we're seeing a lot of pressure from the government and payers in terms of kind of trying to restrict payments, especially for third-party payers and government payers. And I've experienced that firsthand. And sometimes some of these claims about the psychiatric services that we provide are not valid, but sometimes it's just kind of they take a life of their own and escalate. And so business leaders need to be very cognizant of that. They have to have a robust compliance program. They have to have a robust understanding of the regulatory landscape in order to be able to navigate these difficult times.
Yeah, and it sounds like you're those in the industry, they have to adapt to like those payers. Unfortunately, that's, working with them. So how do you navigate that process if you're dealing with the payer that may not agree, or you have to do an appeal? I hear that happen a lot as well. How do you work with them to come to a consensus on how to move forward?
So understanding, I mean, the focus should be the patient.
Yeah, the patient.
For the insurer, the client is the patient. Sometimes the client may not be just the patient. The client may be the employer.
Right.
And sometimes getting assistance or asking your patient to get assistance from the employer, sometimes that can help a lot. I've seen that multiple times where their service is being denied. And what ends up happening is that if the patient, or my patient, seeks help from their employer to get services that they feel that they were promised and are being denied by the third-party payer, sometimes that can be a positive outcome. But understanding the landscape, understanding the regulatory scheme, understanding the rules and regulations, and unfortunately, some insurers have rules and regulations of their own that are different from other insurers. And so understanding the policies of those insurers, also understanding the policies of the government. So some, depending on what plan it is, rules and regulations are different, whether it's a Medicare Advantage plan versus a private insurer plan. And sometimes that landscape is very complex and very difficult to understand. So it's not these are not easy waters. These are choppy waters to navigate.
Yeah.
And as a business owner and as somebody who works in the field of psychiatry, these are very, very difficult to understand. And we have to stay vigilant, and we have to seek assistance of a counsel an attorney who is experienced in healthcare affairs, as well as the experience of auditors that would help you in terms of compliance. And sometimes even if you utilize those, you may end up with a negative outcome, but at least that will cushion the landing when you have advice of counsel and we have auditors that were involved in the case. Sometimes that can make things more amicable and less likely to escalate in a unfortunate manner.
Absolutely. And then what is it that you're doing in your own business to adapt to this kind of shift, of what's happening right now?
So one of the things that we are seeing, and it is a trend, and I've talked about it for the last 5 years. So, for example, we know that more than 50% of psychiatrists in the United States now no longer take Medicare.
Oh, really?
Medicare
Okay.
is one of the largest insurer programs in the country, and it caters to the elderly population. And we know that close or more than 50% of psychiatrists do no longer take Medicare, which is quite unfortunate.
Yeah, that is.
And that's the population that in most need for psychiatric help. And basically, psychiatrists don't take that insurance. So I think that is very, very unfortunate. We also see that it's problematic that there's a lot of psychiatrists that are shifting from an insurance pay model to a self-pay model. So more like a concierge psychiatry or direct psychiatry care, meaning that they don't deal with insurance companies. They expect payment from the patient. They'll be happy to provide the patient with billing statements, and the patient is on their own kind of recouping some of that. And that may be a model that will propagate just based on how much the reimbursement is going to decline, that some of the practices may not be able to survive. And to be able to do that, I mean, so as psychiatrists, and I see that in my own practice, we have now more than close to 50% of our patients are self-pay.
Wow. Okay.
We get the
Yeah.
payment at the end of the visit from them. We still have a commitment to Medicare patients. So I have a group of Medicare patients that nobody else would see. I mean, I'm the only provider in that area. So we have that group of Medicare patients, close to 300, 350 patients that nobody wants to see, nobody can see. And basically, we provide them care and services in our area. So I think that those trends, and those trends are going to continue. And we're seeing government reimbursement is changing, is dwindling. Certainly, there's more focus on care settings and outpatient care setting, and trying not to have people hospitalized.
Yeah.
But we're seeing a significantly changing landscape in terms of reimbursement. And unless you adapt, unless you have the flexibility to adapt, if you're an ocean liner and it's going to take you a long time to turn around, you're going to hit an iceberg.
Yeah, absolutely. And it kind of gives me my next question too. Is there like any parts of that like patient workflow, from intake that you wish just kind of ran smoother in the process overall in the psychiatry, in your industry, or just curious to see your thoughts on that?
Sure. I hope that the entire process runs smoother from patient encounter, patient acquisition to other workflows. So in my area, I'm in the greater Lehigh Valley area. My competition is non-existent. My competition are two large health systems where the earliest appointment with a psychiatrist is 8 to 12 months. So that's my competition. And I can intake a patient within 2 to 4 weeks.
That's quick. That's a quick.
So it's a tenfold difference in terms of when can we see a patient. The other issue is some patients balk at the fact that a psychiatrist does not take insurance, but basically it is what it is, and some patients end up just deciding to see us despite the fact that we don't take their insurer because they need to be seen.
Right. Yeah, that's they need the care, right? That's what they're trying to evaluate the
Absolutely.
actual cost versus like what's the
and there are some insurers that we on purpose decided to part ways with.
Yeah.
After difficulties with reimbursement. And it's not a secret. I'm going to say the name, and they can send me a warning letter because I'm no longer in their network. It's United Healthcare and United Behavioral Health. Basically, a lot of psychiatrists. I was the president of the local psychiatric society, and I could tell you a lot of psychiatrists in my area are no longer in the network of that insurance because they basically do not pay. You see the patient, they do not pay, and they make all sorts of excuses why they're not paying, sometimes silly excuses that don't make sense, and basically they don't pay. And so basically we said, well, okay, you handle your patients.
Yeah. Is that the primary reason why, at least in your own business too, maybe your peers, like why they decide to part ways with a specific payer is because of issues like that?
Partially some of the aggressive tactics by those payers.
Yeah.
I can tell you that specific payer that I mentioned actually placed every mental health provider in the Northeast on what we call a prepayment review, meaning they will not pay you unless you send in your records beforehand. And even when you send in your records, they just come up with just excuses not to pay. So, for example, they said, well, each note needs to have the license number of the doctor. Well, that's not realistic. Not even big hospitals have that. The license number of the doctor on each note. That's not so. But basically, they come up with some obstacles like that too. And then when you amend the note and you send it to them, and they said, well, it's untimely. You were too late. So basically, they're intent on not paying. And they could make all sorts of excuses. And what they want is they want the patient to be saddled with the bill, because when patients come to us, they sign that our relationship, despite the insurance, our relationship is a direct relationship. So they're responsible for their bill. If the insurance doesn't pay, they're responsible. And so the insurance wised up and they started sending us releases. They said, if you want us to pay, you have to tell me that if we don't pay you, you're not going to go after the patient. I said, I'm not doing that. And so basically we parted ways. So it's becoming so difficult because some of the insurers, and some are better than others. I mean, I don't want to make it sound like they're all irresponsible third-party payers. Some of them are really entrenched with their community and really supportive. Like we have one large local insurer in our area that they're so good that they trust us that with one treatment modality, transcranial magnetic stimulation, they came to us and said, well, we see that you do a lot of this. We think that it's helpful for our patients, but we want to do a pilot project. So what we did is we did a pilot project with them. We did 10 treatments, and then they reviewed the 10 treatments, and they liked what they saw. And so they actually waived prior authorization for us. So we
That's
can do the
amazing. Yeah.
treatment with no prior authorization on a special agreement with this insurer. So I don't want to make it sound like all insurances are greedy and they're bad and they're not good for their community, but some are better than others. And you got to weed out through those third-party payers and see who you want to work with. And you got the choice as a psychiatrist. You got the choice.
Yeah. It sounds like you said, it's a very complex landscape to navigate because this is just like one payer example, but it could be different story with every single one. And I can see why you would part ways with one that's being extremely difficult, that's just mentally draining and trying to navigate, especially for you and your patients. So thank you for that insight on that piece. I appreciate it. And then as far as like, I'm interested to ask you this too, because I know how it works like on the like family medicine side and other specialties, but like how do you follow up with these patients that you initially see, or like do you perform like manual outreach again? Like how do you keep the business running? I'm just curious how that works in the field of psychiatry.
So I got to tell you, so for a lot with my training in internal medicine and psychiatry, for a lot of my patients, and I speak specifically about the Medicare population, I end up becoming both the psychiatrist and the primary care doctor.
Together.
They
Okay.
they
Nice.
they end up trusting me. They end up wanting to see me on a regular basis. They end up wanting me to do blood work for them. They end up wanting me to prescribe them their regular medications, their primary care medications. So sometimes that happens. And basically we provide comprehensive care, medical and psychiatric. But for other patients, we try to liaison with their primary care doctor as much as possible, especially those that are experiencing medical problems that are intertwined with their psychiatric issues. We try to do that. And we get a lot of referrals from primary care doctors. I mean, a lot of primary care doctors basically realize that they're not able to manage complex psychiatric issues. And so we work with the primary care doctors to see if we can improve care for these patients.
Excellent. Yeah, I didn't even think about you being an internist as well. So like that's an easy transition, I'm sure, in conversation with patients. And they may not
Absolutely.
even initially think about it either because it might come for a psychiatric issue, but then you can mention, I'm also an internist. So yeah, excellent.
Absolutely.
And then what's working well for you right now, and like what's been like harder than expected? So like two different perspectives there.
I think what's being hard is the fact that our patients' expectations are very high. Patients call and they expect that this is more like a DoorDash. They put in their order
Yeah.
and something
Quick.
will materialize very quickly.
Yeah.
And unfortunately, healthcare doesn't work that way. Even
No.
when they're in a large health system, things don't work that way. They expect that they're supposed to be able to send you a message, a portal message, and you're supposed to answer it in like 3 minutes. You drop everything and run to answer their portal message, and that doesn't happen. And so unfortunately, our patients who I love dearly, their expectations are pretty high, are pretty here. And I tell them, I try to meet it sometimes, but like when your expectations is that when you send me a portal message and you expect me to drop everything and answer it, that doesn't happen. It might
Yeah.
be the end of the day, maybe the next day. If it's not an emergency, if it's something that needs an answer or a question. But I think that we have that expectation. But I think what we're also doing, and I can tell you, we're deploying that. We're deploying a lot of technology. So AI, I think, is helpful there. Despite its shortfalls and things, it is very helpful there because you can prep the AI to answer the majority of your patient's questions. How can I set an appointment? Can I reschedule my appointment? Can I do all of these things that patients have expectations that they're going to happen very, very quickly? Can I pay my bill? Can you call in a refill for me? Or can you switch my medications to this pharmacy? So a lot of these things could be handled by AI, artificial intelligence, and we're seeing some success with that. Maybe not to the full satisfaction of our patients, but I think that we're getting there. And the other thing is that patients' expectations also lead to bad publicity. So like I can tell you, for example, we monitor our social media a lot, the Google reviews of practices. I wanted to talk about that because it's a hot topic. And, just a patient doesn't like something and just they give you star on a Google review or a Yelp review or a practice review on Health Grade or something like that.
Yeah.
And they write, "Oh, I gave you 1 star. I would have given you 0 if I have." And then if I have had a choice, and then you have another group of patients who give you 5 stars. So when you look at a good practice, you will see either 5 stars or 1 stars. There's nothing in the middle.
Yeah,
And
there's no
that can tell you how, like, this is the people who gave 1 stars are the people who just, they're disconnected from reality. So I can tell you in my practice, I'm not 100%. I got a 4 stars. I have 150 reviews on my practice site, one of our sites. 150 reviews. They're not all 5 stars. So out of 20% don't like us. And I say, okay, that I respect that. Please go seek care elsewhere. It may not be, people think that may not be welcoming, but then I'm not going to be able to help you. If 20% don't like me, that's actually a good. I mean, politicians win elections with 51%.
50, yeah,
At
exactly
least.
51%.
So if 80% like me, I think
That's
I'm
really
doing
good.
good. That's a good number. I'm happy with that. I will sleep soundly. I don't want a 5-star ratings on my website. 4-star is pretty good.
Yeah.
So that's an issue that a lot of, if you're in private practice, you will deal with, that somebody feel that they were not listened to, or they were asked to pay a copay when they didn't expect that they needed to pay a copay, and then boom, they give you a 1-star review. So this is again that the expectations of our dear patients are here, and we may not be able to meet them, but I think utilizing AI and helping our front desk staff and having the mindset that this is going to happen and being in tuned into that, I think is very, very important.
Absolutely. You can see that's unfortunately what happens. Like you said, private practice, like you get like a random 1-star. Someone says, I've heard that before, like a 0-star. If that was a rating, I'd give you a 0-star, Yeah, that's unfortunate because like you said, and that's funny that you mentioned you see 5 or 1 stars with the really good practices. There's not really like a 2 or a 3. It doesn't really exist. So it's funny that you brought that up. And then you mentioned the Google reviews, but I also was curious too about metrics and reporting. That's always a big thing. Are there any KPIs, that feel stuck no matter how much effort you throw at something? Like it just feels like you can't move the needle. Is there anything like that comes to mind?
So, I mean, we used measurements to kind of gauge success of our treatment.
Yeah.
So we utilize questionnaires. We utilize quality of life questionnaires with our patients. We utilize patient health questionnaires, depression questionnaires, anxiety questionnaires, questionnaires about ADHD, questionnaires about PTSD, as well as quality of life and the WHO disability scales. And we monitor those in patients yearly and sometimes more frequently just to see improvement. For metrics, sometimes I tell my patients, some of the diseases that we deal with, treatment refractory depression, even with our best treatment, I tell my patients, like, I could only get 2 out of 3 better. There's a third person that I can't, with the best modalities that I have, I may not be able to get them better significantly to remission. They may still have smoldering symptoms that bother them, that continue to cause them issues, but at least I would make them as tolerable as possible. But I may not be able to cure or heal at least a third of my patients, or even half of my patients that will continue to have chronic symptoms. Yeah. So I think that's a frustration for us as doctors, as psychiatrists, and that's a frustration for our patients. Because basically, if they have treatment refractory symptoms, basically they're going to continue to suffer.
Absolutely, that's unfortunate, but yeah, it's like you said. I love the transparency. Like you tell them, like this, I'm going to follow this course of treatment, but this is usually the outcome, right? So they have a good expectation of what can happen. Best outcome, worst outcome. So they have the idea of both worlds. And then let's say you solve all these blockers. What does success look like in the next 6 to 12 months for Blue Mountain Psychiatry? Curious about where you want to go in the future.
I think success is we are deploying a new treatment modality. So I actually spoke about it. I did an introductory video about it.
Yeah.
This treatment, transcranial magnetic stimulation, and we use a machine from a company called Brainsway. And it's basically what looks like a helmet that fits on the head and basically applies a magnetic field to the brain. The company has been active at trying to shorten the duration of treatment. When it was first FDA cleared and FDA approved in 2008, they used a different machine that was a figure of 8 machine, meaning just a something that fits on the head. This is the left side of the brain and applies a magnetic field. The treatment at that time was 45 minutes. And it had to be done 5 days a week for about 6 to 8 weeks. As we applied the helmet treatment, we were able to shorten the duration of treatment down to 20 minutes. We also then other treatment measures in the same machine was developed to apply something more intensive in terms of the magnetic treatment that's called theta bursts. And that brought down the treatment to 3 to 5 minutes. Most recently, protocols have been developed to basically do the treatment in 1 week instead of 6 to 8 weeks. So 1 week, the person comes to your office for a few hours, 5 times a week, sometimes 6 days a week. And basically with their treatment, their depression basically responds and resolves. We are also working on a 1-day protocol. So basically treat your depression in 1 day. That is the project that I'm spearheading with Highway Billboard, basically saying treat your depression in 1 day. And there's a little bit of a problem with that. We may not have a lot of we may not a lot of acceptance from the insurance companies because they're used to paying it basically once a day, 5 days a week for about 6 to 8 weeks. Yeah. And they do pay for it, but they don't have an expectation that you're going to be able to get that treatment in 1 day. So we have developed a model for doing this treatment, and patients could self-pay. And so the billboard is going to be on the highway, treat your depression in 1 day, and the price is $29.99. Basically, you come in, you're there from the morning till the evening. Rates of success is about 70%. So 2 out of 3 will respond by 2 weeks, would have their depressive symptoms resolved completely.
That's amazing results. And then what's something you you need to figure out soon, but haven't had time to tackle yet? Is there any issues like that in your business that you've been thinking about, or hey, I need to figure this thing out right now?
So it's a work in progress. Documentation is very important. Documentation both for payment purposes, for good clinical care, and for basically litigation also. Documentation is very important. I was on the cutting edge about 5 years ago. I worked with an AI company that did AI transcription, AI-driven transcription. So basically, they would capture the entire session with the patient, translate that with AI into a readable note for the medical record, and insert it into the medical record. I think that has evolved significantly. Now the AI is more able, as it developed more, as it's an agentic AI, it's more able to fill in the forms, and it's able also to basically help us with documentation, especially document things that are above and beyond, such as psychotherapy that you do with medication management, other treatment modalities that people do, assessment of adverse effects, assessment of patient compliance, and things like that. So I think AI is going to be involved significantly in the field of psychiatry. I know there are some places where therapy bots and chat bots are being involved. I don't see that there's going to be acceptance from patients, because most surveys show that about 70% of patients are resistant to the fact that AI would be somebody that would give them treatment, such as psychotherapy or other treatments. I don't think our patients would be receptive to an AI robot doing surgery on them. No. And who's going to be responsible for that if there's an adverse outcome? Right. Not even an adverse outcome, if there's a complication. I mean, when there's surgery, there's always complications, and who's going to be responsible for that? So I don't think our patients are ready for that yet, but I think they may be receptive to the utilization of AI in, for example, note capture, documentation, surveys, answering their phone calls, setting up their appointments, maybe taking their payments. But I don't think they're going to accept for chatbots to treat them and do psychotherapy and understand the intricacies and the private things of their life.
Yeah. And so they're not quite there yet. So But no,
I
we're
don't
getting
think that
then.
we're going to be there. I can tell you, I don't think they're going to be there. Where I don't think there's going to be acceptance for that. I think patients are clear about that. I don't know how good these therapy and chatbots are going to be, but the nuances of human communication and the nuances of human thoughts is very difficult to understand. Sometimes even for other humans. So, but
Exactly. Exactly. So, no, thank you for your time today. And where can people connect with you online?
absolutely. So I have my LinkedIn profile, Ali Rifai LinkedIn profile. People can find me also on Twitter, and my website is alyrifai.com. That's ALYRIFAI.com. You can connect with me. I'm available to provide consultations to other practices. I'm also available for legal consultations in terms of compliance and assistance in terms of if there are any practices that are facing regulatory or legal issues. I'm happy to provide consultations in addition to the attorney, but I'm happy to provide them a process consultation to help them navigate those difficult situations.
Absolutely. Well, thank you, Dr. Rafai, for your time today. And I really enjoyed kind of diving in and asking all these questions to kind of like get at the source of kind of what you're working on today, and looking forward to the future. So thank you for your time.
Thank you very much for having me. I'm delighted to give a talk to your audience.
Thank you.